Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back to the channel of Stagewise HF Notes. Today we will discuss about chronic heart failure. Okay. In previous class of acute heart failure, we have learned an overview of the long-term medications which are given to a patient of heart failure. Okay. Now we will discuss in detail, step by step, the mechanism and how to use, when to use, and what's the dosage, how to increment the dosage, how to titrate the dosage according to the patient need. All those we will discuss, okay, in this chronic heart failure videos. So let's begin with the name of Allah. So first of all, what's the definition? So it is a clinical syndrome which is characterized by symptoms, signs. What are the symptoms and signs? Breathlessness, ankle swelling, fatigue, and signs: elevated GVP, pulmonary creps, peripheral edema. That is caused by structural and functional abnormality of the heart, resulting in elevated intracardiac pressures and or inadequate cardiac output. So these two things happen. One is elevated intracardiac pressure and second one is inadequate cardiac output. So because of these, there are symptoms and signs. So what is the central concept? The central concept here is congestion. Congestion is nothing but elevated atrial pressures. So whenever the atrial atrias are stretched, they will release the natriuretic peptides now. So that is the hallmark of chronic heart failure. Congestion is the hallmark of congestion is nothing but elevated atrial pressures. So that is detected by elevated natriuretic peptides. Before even the chronic heart failure becoming clinically overt, you can detect that. Okay, because the natriuretic peptides will be elevated because of congestion. This classification you already know. You already know this classification. But just to, this is important. This is important for dieting therapy. Okay, reduced ejection fraction is nothing but less than 40%. Borderline or borderline ejection fraction is 41 to 50%, and preserved ejection fraction is nothing but more than 50%. Pathophysiology we have learned in detail in the video of acute heart failure. Now moving on to the clinical features. Okay, so this also we have learned. So what are the clinical features? Symptoms of pulmonary congestion, symptoms of systemic congestion, and symptoms of low cardiac output. So pulmonary congestion include dyspnea on exertion and paroxysmal nocturnal dyspnea. These are the first symptoms of chronic heart failure: dyspnea on exertion and paroxysmal nocturnal dyspnea. So when the disease progresses, then they will develop orthopnea. So orthopnea indicates severe, the severity is increased. That is orthopnea, and associated dry cough they will have. Okay, and mainly when they lie down, they will have this. Systemic congestion, as you know, peripheral edema, mainly in the ankles and sacrum, abdominal pain and discomfort because of hepatic congestion, ascites, early satiety and nausea because of compression of the stomach by the enlarged liver. Okay, symptoms of low cardiac output are nothing but weakness, fatigue, decreased oliguria, and cognitive impairment, especially in the elderly patients. So those are the symptoms. Coming to the signs. So what are all you congestion of left heart will lead to? So there will be displaced apex beat because of cardiomegaly, S3 gallop because of congestion. Okay, because of congestion there is S3 gallop. Triple murmur you will hear. S3 gallop is triple murmur. Okay, triple murmur. Kintuki is there, no? That is the murmur. Then pulmonary creps. So right heart failure, elevated GVP, hepatojugular reflex. If you compress the abdomen, there will be increased JVP, that is hepatojugular reflex. Peripheral pitting edema, hepatic enlargement, ascites. So signs of low output: cool peripheries because of decreased blood supply to the limbs, and to maintain that, heart will beat fast. So tachycardia, narrow pulse pressure will be there. Okay, and chain stroke respiration, nothing but regularly irregular respiration. This you will know when you see a patient of heart failure, and the mechanism of this chain stroke respiration is also already in depth explained in the classes of and the cardinal manifestation of pulmonary diseases. So that's about clinical features. So diagnosis, as you all know. Okay, signs and symptoms. Diagnostic criteria: 2, signs and symptoms. Second, objective evidence of structural heart disease or structural heart disease. Okay, so symptoms and signs are there. So these two are the first line test. This four, part of the four, this NT-proBNP and transthoracic echocardiogram, ECG, chest X-ray. These are the first line investigation. So NT-proBNP to rule out is the powerful test. Okay, so in non-acute heart failure, if NT-proBNP is less than 125 picogram per ml, then heart failure is ruled out. In acute heart failure, less than 300 picogram, then heart failure is ruled out. That is non-cardiogenic edema. That means, okay. So levels can be lower in obesity and preserved ejection fraction. BNP is degraded by neprilysin. So that's why we should use NT-proBNP to monitor the patients. And echocardiography is the cornerstone. So you can detect LV ejection fraction, chamber sizes, any valvular dysfunction, diastolic dysfunction, pulmonary artery pressure. Okay. ECG you can do bedside. You can have ischemia, prior MIHs, QFs, arrhythmia. Most commonly this one, atrial fibrillation, left ventricular hypertrophy, left bundle branch block. All this you can see. Chest X-ray, cardiomegaly, pulmonary venous congestion, pulmonary edema, pleural effusions you can see. This 4 and this blood test. So up to 5, these are the first line test. Here up to here, these are the first line tests you do in a patient of heart failure. And remember one thing, you should remember, what is that thing? NT-proBNP raises even before the patient is clinically overt, clinically manifest. So before that patient manifest, NT-proBNP will give you a clue, give you a clue that the patient might be having a heart failure. So at the time you can proceed for 2D echo, ECG, X-ray and blood tests. Okay, in blood test same which we described in acute, like CBC, anemia. Okay, for anemia, renal function, electrolytes, LFT, TSH, ferritin and TSAT. In some patients, for selected patients where you suspect some specific etiology, so you can do, if you are suspecting ischemia, you can do angiography, coronary angiography. You are suspecting some fibrosis, infiltration or inflammation of the cardiac tissue, for example in autoimmune disorders or amyloidosis, something like that, then or tuberculosis like that, you can do cardiac MRI. Okay, now if you are suspecting some vasculitis or infiltrative diseases, then you can do endomyocardial biopsy. So these are the 3 specific tests. One is angiography, one is MRI, one is biopsy. Now coming to the main important topic. Okay, main important topic. See here. So first of all, we will divide this management of heart failure into management of reduced ejection fraction, one thing, and management of preserved as well as borderline ejection fraction, another thing. So 2 things we will divide: management of reduced ejection fraction and management of preserved as well as borderline ejection fraction. So see the mechanism. What is the goal? The goal is to antagonize maladaptive neurohormonal systems. Okay, each and every word is important. How should you start? You should start with low dose and go slow. Start low, go slow is a, what do you call, it is a saying in diabetes patients also, in hypertension also. Whenever you're starting, you start with low dose and titrate slowly. Okay, until the patient has some adverse effects or the goal is achieved. Titrate to the maximum tolerated or target doses. Start low, go slow, meaning start at low doses and titrate slowly till the target dose is reached or the patient experiences adverse effects. So here you can see, I can't zoom it in furthermore. See, renin will convert angiotensinogen to angiotensinogen 1, that is converted to angiotensin 2 by ACE, which is present in lungs. Okay, one side ACE converts angiotensin 1 to angiotensin 2, on another side it breaks down bradykinin to inactive peptides. This bradykinin causes vasodilation, and one more thing, this bradykinin is responsible for ACE inhibitor cough also. ACE inhibitor cough. Okay, so that is one thing that is going to happen, no? So after that, angiotensin 2 will the Rais system is activated, so aldosterone will be produced more, that causes salt and water retention, and angiotensin 2 will also cause vasoconstriction along with vasopressin. Okay, and there will be these two are the important things, no? Angiotensin 2 and enhanced sympathetic activity. So these two are the things which we are targeting. So everything is targeted. See, ACE inhibitors will target the ACE enzyme here. Angiotensin receptor blockers will target angiotensin 2 receptors, and they will be divided again into 1 and 2, all those things. Okay, so ARBs will target the receptors of this one, and mineralocorticoid receptor antagonists like spironolactone, spironolactone or eplerenone. So those will inhibit they are aldosterone agonist. Okay, aldosterone agonist, and the salt and water retention is tackled by the diuretics. Beta blockers will take off the enhanced sympathetic activity. This is how we are targeting each and every step of this circuit. So that's the mechanism of action. Okay, so what are the drugs? The drugs are AC inhibitors, ARBs, beta blockers, mineralocorticoid steroid antagonists. One more is SGLT2 inhibitors. Okay, and diuretics for symptomatic relief from congestion. So foundational quadruple therapy, this is known as 4 horsemen therapy. Okay, starts as soon as possible whenever you detect a patient with heart failure or a patient which is getting stabilized from acute stage of heart failure, and try titrate within 3 to 6 months. Okay, so number 1 in that is ARNI. ARNI is nothing but angiotensin receptor neprilysin inhibitor. So the famous combination is sacubitril and valsartan. So this is neprilysin inhibitor, and valsartan is angiotensin receptor blocker. So what is this neprilysin? This neprilysin, actually, neprilysin, it breaks down the atrial natriuretic peptides to some products. Okay, so these will cause diuresis actually. So they will relieve the congestion and they will have beneficial effects. Okay, they act as diuretics, but this neprilysin is breakdowning this. So what we are doing is we are inhibiting this with an inhibitor known as sacubitril. So that's how these will be preserved, and these will cause more and more diuresis. And in the coming flowchart you will see the effect of each drug, how much they reduce the mortality of the patients. Now this is the first line preferred over AC inhibitor ARB for symptomatic patients of class from 2 to 4. Mechanism is dual action, blocks angiotensin 2 receptors and inhibits neprilysin, increasing beneficial natriuretic peptides. Okay, what is the dosing? Start with 49 mg of sacubitril S and 51 mg of valsartan, total of 100 mg BD. Start with 100 mg BD and titrate to 200 mg BD. Now if you are replacing this combination ARNI with ARB or AC, you have to replace, or vice versa. For example, if you are replacing ARB or AC with ARNI now, so you need to require a 36-hour washout period. So before 36 hour you should not give or you should not replace these drugs. ARNI with AC or ARB, or AC or ARB with ARNI you should not replace until unless 36-hour washout period has it is done. Okay, 36-hour washout period is gone. Okay, before initiating AC inhibitor or ARB. So what are the contraindications? So any angioedema, allergy, hypotension. If the BP is going less than 95 mg, then this is a contraindication. Severe renal. What is severe renal? If the eGFR is going less than 30, that is severe renal. Or hepatic. What is severe hepatic impairment? That is child puck C. If the patient is having hepatic impairment, then these are contraindicated. Okay. Then the next important drug, very important, beta blockers. They also reduce the mortality of the patients with heart failure. So namely these are carvedilol, bisoprolol, metoprolol and nebivolol. Nebivolol and carvedilol, in addition to having specific beta 1 blocker activity, they also have vasodilator property. Nebivolol by nitric oxide, it reduces nitric oxide, so that's how it causes vasodilation. So because of that dual action, mostly these two are preferred for cardiac failure patients. Okay, otherwise we can also use bisoprolol, metoprolol also. Okay. Now when you should initiate, start once patient is n-volumic, even during hospitalization, n-volumic, and target heart rate should be 55 to 60 beats per minute in sinus rhythm, as I said in the previous video. This is an example for dosing. Example, bisoprolol start at 1.25 mg OD, target to 10 mg OD. Okay. Now the third important drug is mineralocorticoid receptor antagonist. Again, this also decreases the mortality of the patient in heart failure. Okay. So for all symptomatic patients from class NYHA 2 to 4, despite ACE ARNI beta blocker, so if the patient has symptoms and the ejection fraction is still not improving in spite of giving ARNI plus beta blocker, then you should use these drugs. So first ARNI, AC, ARB, second beta blocker, then you should go to MRA, mineralocorticoid antagonist. Okay. So when you are using this, you should monitor potassium closely and creatinine closely. How? At first week, within 7 days, you should do this creatinine electrolytes, and after 1 month you should monitor. Then every 3 months you can monitor. Every 3 months you can monitor. Okay. Target potassium is 4.5 approximately, but target potassium should be less than 5.0 millimole per liter. Okay. Dosing, for example, spiraloctone 25 mg OD. You can start it with 12.5 mg OD and it decrease it to 25 to 50 mg OD. Okay. You can use eplerenone if gynecomastia is a concern. Now, SGLT2 inhibitors also decrease mortality, but the important thing is they reduce heart failure hospitalization. So exacerbation frequency they will reduce, regardless of the phenotype of heart failure, whether it is reduced ejection fraction, whether it is preserved ejection fraction, whether it is borderline ejection fraction. Okay. And whether the patient has diabetes or he doesn't have diabetes also. So regardless of the diabetes status, you should use SGLT2 inhibitors. So among these two, empagliflozin is preferred in patients with heart failure, but both can be used. Okay. 10 mg OD is the dose for dapagliflozin, and for empagliflozin it is 12.5 mg OD, and you can increase it to 25 mg OD. Okay. Adverse effects, because they excrete more glucose from the urine, so you should watch for genital mycotic fungal infections and rare euglycemic diabetic ketoacidosis. Okay. So patient, whenever he is sick, he should be given the sick day rules. He should drink water. If his sugars are increased, he should take some 10% increased insulin. All those are sick day rules. Okay. Stop temporarily these SGLT inhibitors. All those things we should explain to the patient. See, this is the flow chart, easy flow chart. Okay. So this is HFrEF. So the ejection fraction is less than 40%, and signs and symptoms of heart failure 2 to 4. Now one more point is, if the patient has atrial fibrillation with heart failure, and then you can use digoxin. Digoxin does not reduce mortality. Okay, digoxin or amiodarone you can use. Digoxin use only when the probability of having an accessory pathway is excluded. Then only you should use digoxin, accessory pathway. So atrial fibrillation with heart failure, you should use amiodarone or digoxin if accessory pathway is excluded. Okay, or else you should use calcium beta blockers you should use, but not in acute phase. Okay, for rate control you can use beta blockers, but not in acute stages. So now heart failure are there, signs and symptoms are there. So assess and manage the underlying cause and risk factors, dyslipidemia, diabetes mellitus, hypertension, all this you should manage. Initiate diuretics in case of symptoms of volume overload. There are symptoms of congestion like pulmonary edema or systemic congestion, pedal edema, you should give diuretics. Then start GDMT, treat the cause, treat the congestion, start GDMT. What is this? ARNI, beta blocker, MRA and SGLT2. When you should use MRA should be used when the patient, even after using ARNI or ACE inhibitor or ARB plus beta blocker, if his having the symptoms or ejection fraction is not improving, then you should use mineralocorticosteroid receptor antagonist. Okay, and in all patients you should use SGLT2 inhibitors. Now next, how do you adjust now? Consider additional management. Now for example, the patient is in sinus rhythm, but heart rate, in spite of maximum dose of beta blocker, or if the beta blockers are conjugated, it is more than or equal to 70 beats per minute, you can use ivabradine. Ivabradine also has some evidence of reducing the mortality in patients with heart failure. If the patient has recent HF hospitalization, then you can use this very C guat. This is guanylyl cyclase inhibitor, which is found to reduce the rate of hospitalization in HF patients. Okay, if the patient is of African American origin on optimal GMT or unable to tolerate, this is important. If the patient can't take this AC, ARB, ARNI, then you can give hydralazine and nitrate in these patients. Not rate controlled atrial fibrillation or persistent symptoms even after giving this GDMT, then you can use digoxin. Okay, rate is not controlled in spite of beta blockers, or there are persistent symptoms even after the maximum doses of this GDMT, then fifth drug you can as a fifth drug. 4 horsemen, this is fifth drug. The fifth drug you can use digoxin. Now reassess the symptoms and ejection fraction. You reassess symptoms and ejection fraction, you should assess every 3 months. Now if the patient has the ejection fraction of more than 35% and now he doesn't have any breathlessness, low risk, then continue the current therapy. If the patient has low ejection fraction less than 35% and he has breathlessness, then you should think of cardiac resynchronization therapy or intracardiac defibrillator. Why? To avoid sudden cardiac death, because in these patients there is a risk of sudden onset of ventricular arrhythmias. So whenever there is some R on T phenomenon like that, or something, some trigger which is triggering these ventricular arrhythmias, so these ICDs will they will avoid those, they will suppress this that arrhythmias profile. So you can use this as primary also, prevents prophylactic also, as well as secondary also, after you have when patient is recovered from has recovered from ventricular arrhythmias. Okay, so in patients with less than 35% and breathlessness, you should consider cardiac resynchronization therapy and ICD. Now advanced heart failure despite medical and device optimization and addressing the cause, then consider mechanical circulatory support or cardiac transplant, or refer for palliative care. Okay, some important notes here. Here you should see, in patients with AF and rapid ventricular rhythm, in case of hemodynamic instability, okay, if there is AF and heart failure, use electrical cardioversion. If arrhythmia cannot be quickly controlled with pharmacotherapy. If this is not feasible or is contraindicated, then use IV amiodarone. Alternatively, IV digoxin for rate control after excluding unnecessary conduction pathway. As I said, you can use IV amiodarone. If there are no features of here there is hemodynamic stability, you should use cardioversion. If there are no features of acute hemodynamic decompensation, control the heart rate by beta blocker. Add digoxin if necessary then. Okay, so if the patient with heart failure with AF is not stable, so you first try electrical cardioversion, and if it is not feasible or contraindicated, then you can try IV amiodarone. Okay, now if the patient is stable on atrial fibrillation, then you just control the rate by beta blocker, and you can add digoxin upon that. Okay, now the second note, in patients with ejection fraction less than 35% receiving a beta blocker and AC inhibitor at optimal doses, so use caution in patients. So what you should use here? You should use mineralocorticosteroid antagonist, MNA. So when the patient has less than 35% ejection fraction, even on beta blocker and AC or ARB, you should use this one. On that, the patient should not have potassium more than 5 and creatinine more than 2.5. So the creatinine should be less than 2.5 and the potassium should not rise more than 5. That you should have in your mind. That is the indication for mineralocorticoid antagonist. One more indication for mineralocorticoid antagonist is this one, use of. If the patient is hospitalized in the previous 6 months and if the NT-proBNP is more than 500 picogram in men or more than 750 in women, then also it is an indication for using this mineralocorticosteroid antagonist. So 2 indications. So ejection fraction is less than 35% or NT-proBNP is more than 500 or more than 750. These are the two indications of using MNA. Okay, this is about ivabradine. Okay, beta blockers when they are contraindicated, you can use ivabradine. This is about hydrolysin and nitrates, where the patient can't take AC inhibitors and ARBs. And consider CRT and ICD for appropriate patient based on society guidelines. ICD is indicated for primary as well as secondary prevention of sudden cardiac death. Okay, the funda behind that I have explained. What's the time? Okay, we'll finish reduced the therapy of reduced ejection fraction. See this diagram. So this diagram shows at what time what steps should be taken. How to start GDMT. See here. Time course of diuresis for a patient presenting with approximately 25 liters of Narcica. Note the brisk response once the furosemide infusion was started and the timing of introduction of long-term medication. Okay, see here. The patient has the weight of the patient is approximately 110 kg here. 110 kg, and here at this point, meaning at some 6th day, they have started the furosemide infusion, and there is brisk diuresis after that. Some approximately 20 kg the patient loses the weight, and at this point, what is this point? You can say at 9th day. Okay, at 9th day, they have started AC inhibitor. Yes, of course, at low dose. Okay, then again they have continued this infusion, and at this point, when the patient is stable on some point IV diuretics, now they have introduced oral diuretic. Okay, so before discontinuing infusion, you should give oral diuretic, then you should stop the infusion, then you should again reassess the patient whether the patient is accumulating fluid or not. Okay, so at this point they have given oral diuretic. After that, in approximately 16th day, they have started the beta blocker. See, this is how we should manage a patient who is presenting with acute on chronic heart failure. That's how to introduce drugs. Okay, so first AC inhibitors they have introduced, then beta blocker after 2 weeks. This is very early they have initiated. You can say at 8th or 9th day only. Okay, so as soon as the patient becomes N-volumic, you can start GDMT, starting with AC inhibitor ARNI. Now this is a flowchart which shows the reduction of mortality with drugs. You can see here ARNI instead of AC inhibitor or ARB, it is reducing the mortality. This is the graph of mortality. Okay, see how much mortality is reducing here. ARNI is reducing so much of mortality, and if you see here AC inhibitor and ARB also they are reducing mortality, but the reduction in mortality is very much less than ARNI. That's why ARNI is the first line drug for heart failure patients. Now again, if upon those, if you use beta blockers, again they will have some reduction in mortality. MNA will again reduce some mortality. If you use SGL2, again they will bring the mortality to here. See, when you are adding all the drugs, the mortality comes from here to here. Very soon again you are adding, again it comes down up till here. Okay, that's why this GDMT is very important. This is from Harrison textbook. Okay, when you are using moxonidine, this is a centrally acting alpha agonist, so used for BP. So you should not use moxonidine in cardiac failure patients because it increases the mortality. See, the mortality is increased from here to here. Moxonidine should not be used. And effective adjuncts, you can see here. So omega-3 fatty acids and iron supplementation is effective adjunct in patients of heart failure. So you can use omega-3 fatty acids, very beneficial, and iron supplementation in these patients. Special populations, you can use ivabradine. Already you know where you should use, discussed already, and nitrates or hydrolysin. So ineffective adjuncts are erythropoietin. So you should not use erythropoietin for anemia and cardiac patients. It is ineffective. Warfarin or low dose rivaroxaban to prevent thromboembolism. When there is no high risk feature and you are using anticoagulants, no benefit. SSRI for depression, no benefit. Statins for heart failure, no benefit. Okay. So the important thing which you should remember is omega-3 fatty acids and iron supplementation. These are having benefits. Okay. So these are adjunctive or second line agents. So diuretics you should use loop diuretics when there are congestion. Ivabradine, if beta blockers are contraindicated or on maximal dose heart rate is more than 70, you should use. Reduces the HF hospitalization. Where is Sivagat for recent HF hospitalization to reduce the risk of repeat hospitalization. Digoxin we should use for symptomatic patient despite optimal therapy, optimal GDMT. If the patient is having optimal GDMT, if the patient is having this one, then you should use digoxin, especially to control ventricular rate in atrial fibrillation. So digoxin when it should be used, so after excluding accessory pathway you should use this one, and after optimal therapy, even if the patient is having symptoms or reduced ejection fraction, you can try digoxin. Use low dose 0.125 mg per day, higher risk in women. Okay, and these hydralazine and diazepam consider if these are contraindicated. Okay, drugs to avoid negative inotropes like verapamil and diltiazem, and class 1 antiarrhythmics, for example procainamide, this is 1A, quinidine, propafenone, flecainide. So these are all class 1. You should avoid these drugs because they have negative inotropic property, they will decrease the contractility of, you should avoid this. Then you should avoid nephrotoxic or pro-congestive drugs like NSAIDs, they will cause salt and water retention. Pioglitazone, very commonly used in patient with heart diabetes, no? So these two will cause congestion also, and they are nephrotoxic also. Dronedarone, which is a brother of amiodarone, increases the mortality. Dronedarone should not be used. Moxonidine also increases mortality, you should not use this antihypertension drug. Okay. Now this is a very good and very lovely chart where you will have whole summary. Okay. So this is a recommended chronic therapy by stage of this one, heart failure. Okay. At risk for heart failure, for example, but the patient is asymptomatic and structural disease, treat the risk factors like hypertension, lipids, diabetes mellitus, stop smoking, stop alcohol consumption, increase the exercise. Okay, and if you are finding any hypertension or diabetes, coronary arteries, you should start AC inhibitor and ARB. Now they have developed some structural heart disease like CMP, cardiomyopathy or LVH, but still they are asymptomatic. Then you should give stage 8 nothing but AC inhibitor or ARB. Along with that, beta blocker you should add if they have MI or CAD. Okay. Now if they have developed the symptoms, then A, okay, plus diuretics which reduces the sodium along with beta blocker. Okay, that is like B plus C you should do. Now if the ejection fraction is low, less than 40 or less than 35, ARNI, ACE inhibitor or ARB, beta blocker, aldosterone antagonist, SGLT2 inhibitor. So these are GDMT, no? All those 4 you should give in stage C. So plus or minus you can give ICD for primary prevention. Okay, nitrate or hydrazine, and plus or minus digoxin as a 5th drug. You can use it as a 5th drug with low dose. Okay, this is about reduced. If the ejection fraction is preserved, okay, so at that point you can use AC inhibitor or ARB. Plus beta blockers are not having any evidence of decreasing the mortality in patients preserved or borderline ejection fraction, so it is not negated. AC, ARB, mineralocorticoid antagonist plus SGLT2, this triad is used in preserved ejection fraction. Okay, refractory HF, okay, consider IV anotropes, ventricular assist device, transplant, end of life care. Okay, now this is chronic HF, this is based upon ejection fraction. Okay, so every detail is covered up in these charts. If just you this is summary of whole thing of treatment of reduced HFrEF. Okay, diuretics you should use loop plus thiazide if there is symptoms. So RAS inhibitor, choose either ARNI or AC or ARB. 36 hour washout period should be there. ARNI is preferred over preferred RAS inhibitor in 2 to 4. Okay, Valsartan sacubitril. Okay, AC inhibitor, so first you should choose ARNI. If this is not possible, you should go to AC inhibitor. If this is not possible, you should go to ARB. That is the order in choosing RAS inhibitors. ARNI not possible, AC not possible, ARB. Okay, beta blocker in conjunction with RAS inhibitors we should use, and beta blockers are contraindicated in acute decompensated heart failure. Okay, that's one thing, they decrease the mortality and hospitalization. Aldosterone antagonist, so add after, this is what, add after RAS inhibitor and beta blocker if the patient has adequate renal function without hyperkalemia. Okay, without hyperkalemia, and ejection fraction is still less than 35%. So mainly in patient, so two indications, no, aldosterone antagonist you should use. There are two indications. One is with the patient still after taking RAS inhibitors plus beta blockers, if still he is having decreased ejection fraction less than 35%, you should use aldosterone. Second indication is if the anti-pro-BNP is more than 500 in men, 500 in men or 750 in women, then also you should use aldosterone antagonist. SGLT2 inhibitors, regardless, you should use in all patients of heart failure. So same thing is continued here. So you should use this if the patient is not able to tolerate ACE inhibitor or ARB, or in black patients with class 3 to 4. They are not much effective as RAS inhibitors, but they decrease the mortality yet. Okay, ivabradine, if the ejection fraction is less than 35%, okay, heart rate is more than or equal to 70. Okay, digoxin, it decreases the HF hospitalization, but there is no change in mortality. Increased mortality with increased levels. That's why you should use low dose 0.125 mg. Optimal serum level should be 0.5 to 0.8 nanogram per ml. Very sugat. So it decreases the CAV mortality and HF hospitalization. Okay, this is important. Those are four very important, and these are additional agents we can use to decrease the mortality. Then cardiac resynchronization therapy. Consider if the ejection, we have learned in the previous video. If the ejection fraction is less than 35%, LBB is there, and QRS duration is more than 140, okay, and the patient is symptomatic, then you should try cardiac resynchronization therapy. Okay, ICD for primary prevention if ejection fraction is less than 35%, or secondary prevention also you can use. So sudden cardiac death, it will reduce. Okay, then iron supplementation. When you should use iron? If the ferritin is less than 100 or it is between 100 to 300, that means the ferritin level should be maintained above 300 in patients with heart failure. Ferritin level should be maintained above 300. Okay, and if the TSAT is less than 20, that means TSAT should be maintained 20 to 40 in heart failure patients. Same is the case for CKD patients also. Anticoagulation, if atrial fibrillation or venous thromboembolism or left ventricular thrombus is there, then we can use anticoagulation. Heart rhythm, if atrial fibrillation and NYHF 224 with ejection fraction less than 35%, catheter ablation can decrease the HF hospitalization. Okay, what is the BP target? This is important. Less than 130 to 80 is the BP target. Diet and exercise. Avoid the meds, NSAIDs, calcium channel blockers, TZDs, and one more is moxonidine. Okay, so these are master flow charts of heart failure. So this is the last table we'll discuss, and other things we'll discuss in the next video. So this table is from Harrison. This is about the dose. See here, AC inhibitors. When you are starting, for example, lisinopril or enalapril or captopril, this is the initiation dose, and this is the target dose. ARBs, losartan, valsartan, candesartan. This is the initiation dose. Valsartan, you remember 40 BD, and the target dose is 160 BD. 160 BD. Okay. Then aldosterone antagonist. First we will move on to second. We will add beta blockers. No, this is second, beta blockers. So metoprolol, carvedilol. So metoprolol dose start with 12.5 to 25, go up to 200 once daily. Or carvedilol 3.125 twice, or go up to 25 to 50 BD. Bisoprolol 1.25. Okay. Then if required, aldosterone antagonist. Two conditions. No, two indications for giving aldosterone: ejection fraction and anti-BNP. Spironolactone start with 12.5 to 25, target 25 to 50. Eplerenone start with 25, target is 50. Now these are the other drugs. Okay, this is important. Angiotensin ARNI, sacubitril valsartan, start with 100 mg BD and go up to 200 mg BD. Other drugs, this one is important. Dapagliflozin and empagliflozin start with 10 and target is also 10 only. Target is also 10. The next to that will be verisuagat. Start with 2.5 once daily, go up to 10 once daily, 2.5 and once daily. So these are the drugs which are used instead of if you can't use RAS inhibitors, you should use these drugs. Start with 37.5 to 20 mg TID, go up to 40 mg TID. Okay. So that's how this is all about the therapy of heart failure of reduced ejection fraction. In the coming class, we'll discuss about the complication, the management of preserved and borderline ejection fraction complications, and a case sheet. A case sheet we will discuss from Oxford, so that a patient which is hospitalized and which is recovering, how to start the dose, how to increase the dose, and what a case sheet in the form of case sheet at the end of the chronic heart failure class. We'll discuss that. Okay. Thank you for your listening.